Dr. Ayse Gurses is an associate professor of anesthesiology and critical care medicine at Johns Hopkins University School of Medicine. She also has a joint appointment at the Hopkins Bloomberg School of Public Health's Department of Health Policy and Management. Her areas of expertise include human factors engineering, patient safety, healthcare technology design, and implementation and usability evaluation. She is our next candidate for the Center Director of Health Services research job. We're very excited to have her here. The name of her talk is Improving Care Transitions and Teamwork, a Human-Centered Design and Implementation Approach. We will have some time at the end for questions, but until then, please take it away.
Thank you. Thank you so much for the invitation, the virtual invitation, and your flexibility. I am enjoying meeting faculty. I learned a lot over the last few days, spread across the week. So, and I would like to share some of what I do, my work. This is only a line of work. I won't be able to share every major project I do. And of course, I welcome questions during the meeting, during the talk, after the talk, and even after today. So just, I was asked to provide a few words on myself. So I am an engineer, industrial and systems engineer by training from Virginia Tech and University of Wisconsin-Madison. Then I did a year of postdoc at University of Maryland Shock Trauma, actually, and moved to Minnesota, which you don't see from here, for a year before I'm University of Minnesota Health Policy and Management, before I moved to Hopkins. And at Hopkins, I am a faculty at School of Medicine, but I also got a career grant, and during that I got an MPH. I started grant writing very early in my career, and I really encourage any PhD students who are interested in faculty positions doing that. I got my dissertation grant, and that was the start of my grant writing, and never stopped. Luckily, have been successful so far. I have several interests and focus areas. I'm definitely interested in, and some of this you will hear today, distributed work, cognitive work, and team-based work, and how do we redesign work systems, healthcare work systems, to support distributed work. And this can be both care professional work, care professional teams work, but it can also be patient family work. And you may have heard some of this from Rich Holden already, also looking at the patient family work system and redesigning work system, patient family work system to support healthcare. I am pretty interested in infection prevention and control. Started with many years ago, it started actually, but then when Ebola outbreak hit, I was there at the right project, right time, basically. I was involved with the Ebola training development that was posted on CDC's website. And after that, we got several CDC funded research projects on Ebola, environmental cleaning, patient room cleaning, and recently I have been working on COVID-19. I am, since my PhDs, I have been very interested in workload, especially nursing, ICU nursing workload. And this is becoming, again, a topic of more interest and hopefully more funding, which I am now just got a I am a co-investigator on an R01 we just got in NICU nursing workload. In terms of interests, I use mixed methods approaches. I really believe in participatory design approaches and human-centered design approaches. You need to design things, redesign things with the stakeholders being on table. My thinking process are influenced by or my researches are influenced by several conceptual frameworks or models, including socio-technical systems theory, distributed cognition, and resilience engineering. And I do research in a variety of care settings, interested in also in between care settings, what happens to people. Currently, I'm an associate professor with several joint appointments in engineering, health sciences, informatics, School of Public Health, in addition to medicine. The reason for these is I am, again, truly a believer in multidisciplinary research, and this helps me work in the intersection of disciplines and develop more interesting research questions and grants. I'm the director of the and founding director of the Armstrong Institute Center for Healthcare Human Factors that bring together clinician researchers, PhD, master's level researchers interested in any shape and form of human factors, engineering methods and tools and approaches. I have mentored and been mentored by several of my mentees, several of the K grant mentees. I have several K grant mentees, many, like probably 7, 8 postdoc student fellows, PhD, DRPH students, master's students, and some research coordinators, some of them like MDs or MS level people who want to play a research coordinator, research manager type of role. And they are, they have been, if they didn't graduate, they are with, like the research managers are most of the more permanent staff. I teach also a course in School of Public Health, regular course once a year. I just finished actually 1 hour ago. I was guest lecturing in biomedical engineering. I have taught in the past when they need some operations management type of courses in business school. And I also teach or lead the teaching of some national and international workshops on patient safety and human factors. And scientific and departmental editor for 2 of the journals here, Applied Ergo, which publishes a lot on healthcare. So I'm the scientific editor responsible for healthcare submissions in that journal, and also IIE, Institute of Industrial Engineering Transactions in Healthcare journal. And if you are interested, this is not the most updated, but still gives a good amount of information about our centers and some of our projects, if you want to visit. Here are some highlights from current research. These are not the complete list, but today I will talk about some of them. The care transitions and teamwork in peds trauma I will talk a little bit about that. I also have a recently awarded diagnostic safety R01, looking at the diagnostic safety process in 3 EDs, one urban, one urban and academic, one community, and one rural, and see how the diagnostic process unfolds and happens in these 3 very different settings. I have done some work, just finished some work on medication safety, and then recently, based on that, we have received a new Learning Lab Award focusing on medication safety in primary care this time. Again, just 2 weeks ago or 1 week ago, we got an internal grant to study PPE use during COVID. So I will be leading that effort. That is an internally funded project. And I collaborate with also many smart other faculty both within and outside of Hopkins, as you can see across different projects with geriatricians and also which for NIA and then infectious disease control people and also an ICHT for the NICU project I mentioned on workload. And I have, as explained, have several mentoring, many mentoring efforts and experiences. Two of the current ones are the I mentored two junior, one of them is not that she got promoted to associate, but two K grant awardees, 5 years each. Then I have also mentored 8 postdoctoral research fellows. These are people usually who have PhDs from human factors or a related field interested in healthcare. And one of them, Priya, was the one who received an NLM National Library of Medicine Pathway to Independence Award, given some of the work we have done on cognitive engineering with her. I have also been a PhD advisor for MD Ash, who is an MD doing residency now, who has received some awards, including the Best Poster Award in the one of the conferences. Okay, so some of the key points of my talk today. I have an approach that I try to, as an engineer, although it's human factors engineering, I focus on we as human factors people or industrial and systems engineers look at the processes, sub-processes and work systems and try to improve these by redesigning the work systems with the goal of improving people's performance. So most of my work focuses on these more complex work system designs or redesign efforts. I use participatory and human-centered design approaches. You will see some of that in my discussion today. And I am a believer in tailoring the interventions to local context. And you will see some examples of that today. And how can we, I'm also very much interested in how to speed up the learning process in our healthcare organizations and also across organizations. And you will see some highlights of that also. And one of the major things when we look at some of the projects, some of the care transitions work I have been involved in was support of team cognition, was distributed cognitive teamwork was a major need, or lack of that was a major flaw we have identified. So I also strongly believe in the potential, if designed well, the potential of health IT to improve care coordination, team cognition, and distributed cognitive work. With those key points, I would like to talk about some of my work in care transitions as an example. And as you can see from these pictures, there are different types of care transitions. That is basically a process here, some of the care transition process. And this is Rich Holden's first author paper that I had the privilege to work with him on this paper. So we look at care transitions as a process and what are the work system elements that affect that care process, the care transitions process and outcomes. So we are looking at, in some of these projects I will talk about, the different components of the work system that affect care processes. This is a related, I will talk about 3 related studies, one after another, just highlighting key parts they are all related, and they were built one upon each other. So they tell a story because of that. But you will see how our thinking have evolved over time with that. So in the first study, we weren't actually looking at much of care transitions specifically. We were in the cardiac operating room using multiple methods to understand safety risks and prioritize safety risks from different lenses, from different perspectives. So that means we had cardiac anesthesiologists, our team, some health services researchers and human factors engineers, and also nurses. So we use multiple methods, including direct observations and contextual inquiry that most of my slides come from that, or pictures. What we have seen is a great example of a complex work system with tools, technologies, environment, physical environment, etc. And we have actually found many workarounds on use of technology in that study. You can see these are not when you look at these pictures, these are some real pictures from the wild, basically, but they are some of the top cardiac surgery centers in the US that we have observed. You can see all this not very organized use of space and lack of physical space, horizontal space especially, a big problem. You see how IV pumps are all taped with different names of drugs because the pumps were designed in a way to be a bit too fancy to be user-friendly. So the names of the drugs were hard to read all the time, or they were not available actually for like 30 seconds or so, and then appears again, and the anesthesiologist really didn't like it. We identified many of these safety hazards systematically, but we also looked at good practices across sites. So this was the learning across sites idea, how these healthcare centers came together to learn from each other. Like the sponge counting is a good example of that. This one being much better compared to this other one on the right. So this was the first study, mostly in the cardiac operating room. And we have developed different, very detailed taxonomies, and even identified based on that some risky areas. And that led to the second study, which was one of these areas was the care transitions from cardiac operating room to ICU. Actually, we identified one of the interesting things. We realized that the service line, operating room, ICU floor for cardiac surgery, they don't work as one service line. They are working in their silos. They have their own way of doing things, and that has an impact on both quality and safety and costs also. So our project was focused on how can we, the larger project focused on how can we bring these units together and work them as a team, coordinated effort. And the one that I will talk about is specifically focused on operating room to ICU care transition. And as we know from literature, care transitions are risky for many of the patient safety, and cause, if not done well, which is hard to do, can cause several adverse events. So our goals were to identify and categorize these safety hazards, specifically focus on OR to ICU care transitions, and then develop an intervention package and implement this in 4 surgical centers, cardiac surgical centers across the US, using a human-centered participatory design approach. When we started looking at the care transition process from OR to ICU, you start thinking it is probably, you know, OR nurse calls ICU nurse, then patient transported physically, stabilize patient in ICU, and verbal handoff of ICU. Well, if you don't know the process that much, which we didn't at the time, first time you don't realize actually it is even more complex than the picture I have here down. There are many things going on in that process. And most of these things aren't also designed or taught carefully and just organically happen the way things are being done. So this is what we were interested in, looking at this process very carefully. As I mentioned, we had 4 large cardiac surgery centers, 1 in each of these states. These were the sites that volunteered to be part of this initiative. After doing some site visits, we have done site visits, 1 HF person combined with a clinician, doing multiple observations, just similar to what we have done in the cardiac operating room. And we identified some of the problems and then based on that, we co-developed an intervention package and adapted the intervention package to the sites and implemented them. So some examples of problems we have identified. Of course, as you expect, many problems with information transfer and teamwork across units, not including everyone that needs to be included in the verbal handoff process, or not preparing the ICU for something that is not routine, and not informing them, not having a system to inform them appropriately. Inaccuracies in information transfers or lack of information transfers. In addition to all of this information transfer, situational awareness type of stuff, we have also identified several other factors, such as related to, in this case, tools and technologies. Turns out the OR and ICU are using, in 2 of these 5 hospitals, you are using different brands of pumps, IV pumps across units. What happens then is when you are transferring a patient from OR to ICU, you need to change your pump and restart everything. And this is by itself a safety hazard. And when we asked why you don't use a consistent brand, they told us it is more the financial decision. ICUs can get along with a cheaper version of the pump, and that was the decision. That was the reason we were given. So we can see how some of these other factors in the work system, organizational design, organizational culture, is affecting the frontline care, the handoffs directly. When we if we think about the Systems Engineering Initiative for Patient Safety model that Rich has been the lead author of. There were many design issues. I haven't seen any handoffs that mobile transport monitor doesn't create a problem. There is always some problem with it, or the freestanding poles and trying to coordinate all that physical movement of the patient, of the people, and the poles, etc. that are not, and some of these can be, some engineering solutions can be very easily applied to fix some of these issues. After all of this in-depth analysis, because of time, I cannot go into details. What we did is we basically put together a toolkit. This is not the complete list, but it gives some specific ideas. The toolkit consisted of the HF expert and the clinician expert together, going to these sites and giving site-specific feedback based on their observations to these sites. Then before even that, we also asked them, before giving the feedback, we also developed a tool called a self-assessment tool called Assessment of Care Transitions. It is basically a set of questions developed based on literature, based on good practices we have seen across different sites, but based on also science of safety and science of human factors, engineering and design. So we asked sites, each site, to do some self-evaluations of their handoffs, picking 5 to 10 of them, just doing some care transition evaluations and identifying points that they themselves think aren't as strong and have opportunity to improve. And that really led them to be the ones deciding on where to really focus their efforts on. So that participatory approach really helped down the stream. We then also had a lot of some in-person meetings. This was like a 2-year type of collaborative. Some of the meetings, we were meeting with them by phone every week, every other week, these 4 centers, but we were also having them in person every few months to do some activities. And one of these was the teamwork across unit activity, just something simple as what do I need from your unit? What do you need from me? So that we could bring the OR, ICU, and floor people together to figure out what the needs are, and thinking of more of a coordinated system service line rather than people and trying to reduce the blaming of each other. This is how the ORs work and ICUs work, and they don't know what we need, etc. Trying to get the blame out of the picture and trying to focus on improving the process. And some of these we simplified and made the principles from human factors engineering, science of safety, and basically put them into these practical tool formats. But these were all influenced by the science and literature and expertise coming from the safety science and human factors engineering. And there were several other things. One of them was this cross-unit shadowing, which is basically, why don't you as an anesthesiologist go and shadow the ICU nurse to see what they need for just an hour or so, things like that. And some recommendations on supply chain management and buying decisions in terms of consistency in design or in terms of the tools, technologies they buy. And everyone had a checklist, right? There is no care transitions process, or there are not many, that doesn't have a checklist. And nobody either uses it or doesn't feel the need for it. So what we did is we didn't tell them what checklist to use. We gave them principles of how to design a good checklist. So we taught these people or coached them how the basics of human-centered design approach to checklist development. And each center developed their own checklist, little bit different, but it is, when you look at it, it is somewhat similar, but this really also helped improve acceptability. And we have done several types of evaluations, which I won't post, pre-post, and I won't be able to go into all the details, but some of the redesign, this was the toolkit that we gave them, and or some lectures or some coaching calls on principles of coordination, etc. We have done this over a long period of time, but then with them, together with them, we redesigned the process. Here are some examples: standardization of some phone reports from OR to ICU nurse, notification of when the patient is off pump or when the patient is rolling, so that the ICU knows what is going on. Clarification of teams and team roles, and making sure the checklist is redesigned to actually support the process. Reducing interruptions during the handoff process using the sterile cockpit idea from the human factors engineering. Some other things we have been able to make impact on: changing in one of the hospitals, they have came up with this. Change in IV tubing used in ICU was needed, and they all came together and they decided that they can make this easily compatible across the service line. So that was like their QI type of thing based on this process. And performance, we met with them, we asked about their, regularly we asked about their problems and barriers, but also they learned from each other also, joining these calls. So increasing the speed of learning organizations and spreading that learning across these centers. And this project actually led us at Hopkins to develop this idea of clinical communities for QI, which means that we have, I don't know, probably like 20 or so communities now. I don't even keep track of them. For example, for the ICU, there is a community. 5 of the hospitals and ICU leaders every 2 weeks or every month come together, discuss their problems to improve issues. And this was the project actually that led us to thinking in that area, like how to structure and increase the learning process speed across our organization. And we did, of course, one of the challenges with care transitions is how to measure it. And that has been the challenge in our project. So, but we have used multiple ways. One of them was pre and post evaluation of some handoff related questions. These are the handoff related questions, but we have also looked at measures such as relational coordination, which is very well known in the literature. We have also done some post interviews and to understand pre-post and how things are being done post, whether they have gone back to the previous original baseline or not. And we were able to see that there were these were real changes. And some of the hospitals did even further their own individual evaluations, observing some handoffs using the ACT tool that we have developed previously, this one, and now trying to use that tool as an evaluation mechanism to continue monitoring. But we have seen some improvement, at least by the survey results you can see. And this was, we were able to control the individual clinicians. So it was the same clinician. We were able to control for the clinician 1 time 1 time 2, clinician 2 time 1 time 2. We were able to control for clinicians and do the analysis at that level. All this work, and because of time, I will move a bit quickly. All this work made us think and made me think specifically on the importance of supporting cognitive teamwork and how little we understand about not the procedural work only, but cognitive work. And that was my next RO1, basically. How can we redesign healthcare work systems and with the use of well-designed health health IT to support cognitive work? This is the Peds Trauma Day, and this RO1 was focused on Peds Trauma Bay care transitions from Trauma Bay to ICU. But this time, rather than looking at everything in the work system, we were focused on how to support the cognitive work by using or designing technology. And what is the base? It is more like the basic science of how team work happens. And after figuring that out, trying to develop the right types of technology. You can see currently when you go to the ED, you see this trauma narrator, many pages for one patient that stays there probably 20, 30 minutes. You can see the amount of information from that arrow that the nurse who acts as the trauma narrator enters. And this is the information that the PICU, Pediatric ICU, or the operating room, depending on where patient goes, can see, and very, very hard to make any sense of this in such a short time period. So we looked at in this, because of that, we looked at how teams make plans, how do they make decisions in healthcare, how do they assess problems and solve, how do they make sense of things. So the questions were to describe the cognitive teamwork as it happens currently in care transitions of pediatric trauma patients, and simultaneously, based on that, to develop and test design requirements for future health IT to actually support this work. Because as many of you know, current electronic health records aren't always designed to support the cognitive teamwork, or not necessarily always, that's not the primary goal, or at least doesn't seem to be. And in this study, just to give an overview, we used iterative design, contextual design, which is a particular human-centered design approach. But our aim one was basically this basic science, I would call, of how things work in such a complex work system and how teams make decisions, while simultaneously aim 2 is focused on how to design better health IT-based systems to support the teamwork going on based on what we learned from aim 1. So it is a lot of in-depth analysis and constantly thinking about how to design the next set of tools to improve this work. And eventually, the goal is to identify some sort of final design requirements for the health IT, but with the caveat that nothing can be final because our work systems that we work in are so dynamic and complex. So they change any day, as we know. When we look at the roles involved in pediatric trauma, there were 58 different roles located. This is across not only the trauma to ICU, but across the hospital, 7 locations, 58 different roles. And when you look at most of the time how these people coordinate care, what do? They call each other one by one. And this is currently, or perhaps sometimes there's a pager that some information goes to multiple people. We actually did some more analysis to look at the different paths, and we used a combination of EHR data and trauma registry, matched the data and identified multiple ways, pathways that these patients go through. So it's a pretty complex process. but this was like a side project. This paper was a side project, but interestingly, we found a very high level of PQ discharge pathway, more than what we have or what our clinicians thought is happening. Typically, you expect PQ floor discharge and much less PQ discharge. And what happened when we asked why this is happening, and there was a more of a QI type of impact. Okay, the people on the floor aren't as prepared or ready, we think, to take care of these kids. So we make sure they are good, well. By the time we feel like they are well, they are also ready to get discharged. So they were basically using some of the PICU as the intermediate care unit type of thing. And talking about value in healthcare, this was, and PICU is always busy, you know, full. So this was a QI point that they really took serious and tried to improve, at least tried, but, this slide is just telling that team cognition is one of the main, when we interviewed people about these barriers in care transitions in peds trauma, lack of support for team cognition, cognitive work was one of, was the most important thing that wasn't supported, the most important barrier. Then we dived more into why team cognition is not being supported. Lack of situational awareness, goals, people, different teams. These are multi-teams, fluid teams. You don't know who is on your team. And we identified several ways and barriers, and I won't have time to go to all of them, but I want to give some examples. So let's see, this pediatric intensivist says if the kid had an abnormal chest film and had infiltrate, that could be pulmonary contusion or aspiration. So then right way to put that on the problem list is to put it on as pulmonary infiltrate and say, I don't know if it is blood or infection until you get a degree of precision. You shouldn't be typing pulmonary contusion, because that will going to lock people's mindset into the wrong direction. So think about how to represent and present uncertainty on these cognitive tools was an important factor that we have identified. And several examples like that. And because of time, I will skip. We had several design sessions with PEDS, ED, ICU, and surgery, and identified several design guidelines based on what we have seen, and developed a prototype. Basically the prototype, some examples, there is this little person here. You can see where some of these places that he or she got injured, or potential places like there is a burn potentially here. You can see how people wanted to see how giving different medications had an impact on the vital signs. So we are able to show all of that here. The idea is putting this into a large display in the trauma bay and also PICU, so that people get a sense of what is going on with this patient quickly. One of the problems which I just mentioned is uncertainty. So they were really worried about the status of diagnosis, whether something is checked in the patient and whether it is present, it is checked or ruled out, checking and unsure, and not checked. So it was really very important for our clinicians to clarify these 4 points. So that is why you see some marks here. And here, if we go down, you can see the problem list and the different levels of certainty, checked, not checked, checking, unsure, and the interventions for these problems, last actions that were done to clarify and making sure people are on the same page. And several other characteristics of this prototype. Basically, what we are currently doing is scenario-based usability testing, a motor vehicle, car accident, etc., trying to further improve this prototype. So in summary, there is a lot to do for the health services research and health human factors. In my talk, in November, I was talking more on the medication safety in care transitions to home. Today, I wanted to pick a topic in the inpatient area, but there is a lot we can do. The main issue is we really, when we are developing change, we need to make sure that that change leads to really, or to the extent possible, actual improvement, rather than just putting any intervention. And that means really planning carefully and infusing the science of safety and quality into health, the HFE, HSR systems engineering into healthcare, because if we engineer, as my colleague says, if we engineer cognitive systems on the basis of mistaken or inappropriate views of cognition, we can wind up designing systems that degrade performance rather than improve it. So just a couple minutes for my vision for the center. I'm a firm believer, as you can see from some of my research approach, in inclusion, diversity, listening to people, and a participatory approach. Of course, in the end, you need to make a decision. You cannot take forever. But hearing what everybody's saying and really thinking about different perspectives is, I think, really important for innovation and problem solving and improving healthcare. The type of approaches I use in my research actually is also part of my leadership style also. I am definitely very interested in transdisciplinary research and transdisciplinary operations and improvement. Definitely mentoring next generation of researchers and also operational healthcare leaders is key, because if we don't do that, what we do now will have will disappear. So we need to keep that flow going and support the junior researchers and those who will become the next operational leaders. You can also see the type of research I do. I do basic science of human factors, or what I call basic science, health services research. I try to really understand what is going on in the work, how do teams work, what barriers they have. But I do all of that with some goal of trying to improve it. So so in the end, the goal should be some improvement, implementation. I don't believe only doing basic science for basic science purposes. As long as the priority should be doing some of this descriptive work to inform, give insights on improvement and implementation, and hence later leads to dissemination and sustainability. In terms of funding, I am a true believer in not putting all the eggs in one basket. Definitely many opportunities for federal funding, but also thinking a little out of the box and bringing how to engage and bring industry dollars, national and international, and to support both practice but also research. And I have some experiences on how to do that in my current position. And developing some training programs that is part of the dissemination efforts also, or packaging some of our research products also to support healthcare system improvement, not only within our healthcare system, but across the world. In summary, I didn't realize this, but as years pass by, I can now see there are so many opportunities out there if we are interested in pursuing, but if we also integrate our efforts, put our brains together collectively, and align goals and incentives and do smart work and be ready when opportunity arrives. That is another key. In addition to these opportunities, waiting for opportunities, there are many opportunities to create opportunities ourselves. So we can also, I have seen over years, and we can shape the research agenda for health services research nationally and even internationally. So all of this though requires trust, inclusion, and alignment of goals and incentives. With that, I would like to thank you and see probably Dr. Carol whether we have any questions, right?
Just had to come off mute there. Yes, so people should feel free to come off mute and ask questions. If it gets disorderly, we'll jump in, but let's try. Any questions?
Yeah, this is Rich Holden. Thanks so much, Ayse, for a really terrific talk, and for doing it remotely, which can be very difficult. I was looking at your last slide and the be ready for opportunities kind of message, and then I was thinking back to kind of your earlier comments and the recent grant that you just received to study COVID-19. Congratulations. And I wonder if you could talk a little bit about kind of, positioning research to respond to these kind of, whether it's a crisis or whether it's, an emerging federal interest in a topic that maybe, even though you were kind of an expert in studying, like the Ebola outbreak and infection control, but like getting a team organized and getting colleagues organized around an emerging topic like COVID-19.
Yeah, thank you. So yeah, I was lucky, but also as I was saying, I think I was also ready when the opportunity came, and that is how I was telling to some of my friends, like that we got it's not a huge grant, but it is a 300K grant that I spent just one night writing. So it was a great return on investment on that sense. But the reason why it happened that quickly, people knew about our work. And when this opportunity came, Hopkins basically were trying to respond, the Hopkins research were trying to respond the Provost's office to develop a COVID response, research response. And as part of that, healthcare worker safety was one of the important ones, and PPE problems. And all of a sudden, I was asked to put this proposal together. So that is an example of be ready. And in terms of how to organize the team, I mean, I don't know. You just do it. I don't have the greatest systematic way. Probably I know the people to go to quickly, and I was lucky because of my previous experience. So that helped me a lot, and I'm really excited about this new project. I think though thinking little bit, what I realize over time is thinking little, even though you may not feel like super ready, nobody will be super ready, thinking little bit out of box and making these connections between your research and what is out there, and constantly thinking about those and being embedded in a healthcare system. So the minute COVID was happening, I was like hanging around in operational meetings and incident command center meetings, things like that. So being open to what is going on in healthcare centers and using that as an opportunity to think about ideas and organize is basically what I mean by be ready. Okay, that answers the question.
Any other questions? All right, then I'm gonna, on behalf of all of us, Ayse, thank you so much for being so flexible, helping to get this done. And I'm sure if there are any other questions in follow-up, I should be happy to take them. Otherwise, we look forward to continuing to meet with you in more individual meetings. Thank you, everybody, for coming.
Thank you for listening on a Friday evening, afternoon. Thank you so much.